So we are starting off with an extremely simple case, right? Here you have a patient, a young female who has come with palpitations. So it's kind of acute episode, and she's clinically stable. Just have a look at that ECG. We'll give you about a few seconds to have a look at it. Look at the QRS, look at the rate, look at the QRS complex. Right. And let's try to answer some of these questions. Right. What is this arrhythmia? Is it atrial tachycardia? Is it a nodal reentrant tachycardia, like AV nodal reentrant tachycardia? Is it a fast atrial fibrillation? Is it a AV reentrant or atrioventricular reentrant tachycardia, or a sinus tachycardia? You can start voting now. There's a countdown going from 10 seconds. Okay, so we have only 50 people have answered. I don't know why, right? Anyway, we see, right? So, right, out of the answers, 34%. Most of the people thought that it's a sinus tachycardia, right? And about 30% or 1/3 have thought that it's a AV nodal reentrant tachycardia, and the rest have various other answers. So you can see the narrow complex tachycardia, and what is obvious here. Well, or at least what is not obvious here is the P wave. So you really can't see a P wave, right? So you have a narrow complex tachycardia with an absent P wave. Now this is one of the commonest narrow complex arrhythmias that we come across. And why is the P wave absent? Because the P wave and the QRS complex are generated at the same time due to a reentrant mechanism using the AV node. So you have reentrant mechanism using the AV node, and therefore simultaneous activation of the ventricle and atria, and the atria, and the P wave therefore is buried in the QRS complex. So therefore the answer is AV nodal reentrant tachycardia, right? So as I said earlier, it's a narrow complex tachycardia, and there's a lack of P waves, right? If you will also might notice that there is also, if you look at back again, that there is a slight, if you look at V1, there is a small R prime in V1, right? And that is actually the P wave, with the retrograde P wave that is seen in AV nodal reentrant. So the retrograde P wave is seen as R prime. And as an enlarged version we have here, right? That is what you see. So this, and particularly if you compare it with the patient's sinus rhythm ECG, you will realize that in the sinus rhythm ECG, which I haven't shown here, there is no R prime at all, right? But in tachycardia, there is this R prime, and that is actually the P wave, which is retrograde, right? So, and this is a classical AV nodal reentrant tachycardia. Right? We are going to do this alternatively. Any comments from the audience, from the expert panel on this? It's a very simple case, so I don't know if there's anything much to comment.
Yeah, I totally agree on that. The diagnosis. Just to add on, like yesterday, we talked about the AVR being the neglected lead. So even here now, after Dr. Gunawardena's explanation, there is a pseudo R prime. It's not a true R prime. To be called R prime, it should be part of the QRS complex. So you have R wave, then you have S wave, then you have a small R prime. But this is a pseudo because it's a P wave that's reflected upon the R wave. So it's a pseudo R prime. And if you look at the AVR, now knowing that there's a pseudo R prime, in the AVR, you can see that the ST segment is sort of a curved upwards. That's the P wave coming backwards towards the right shoulder. So you can see that's another value of the lead AVR. So you can see the P wave coming down towards the top of this thing. So this is very classical because when the interval between the beginning of the R wave and the P wave is so short, the differential diagnosis is almost always AVNRT. So
if you had picked AVRT as an option there, number 4, you would not have been wrong. I agree that it is mostly AVNRT. The most common arrhythmia is with a short RP tachycardia, where you can really appreciate the P wave, and you see that RSR prime that you come across in V1. The most common diagnosis would be AVNRT, or the differential in that would be an AVRT or AV reentrant tachycardia that is mediated by an accessory pathway, which is you're talking about an orthodromic reentrant tachycardia can exactly look like that, but mere statistics tell you that it is probably an AVNRT until proven otherwise. And it's a common mistake to to imagine that this could be sinus tachycardia, but even with a rate of about 200 beats per minute, you would almost always see a P wave in case of sinus tachycardia if it is either inappropriate sinus tachycardia or exercise-induced EKG manifestation that you come across.
Right, so how would you treat this patient? We have several options, right? So how are you going to treat this patient? Are we going to give the patient an IV amiodarone? Are we going to do a carotid sinus massage? Give the patient IV adenosine? Or do an eyeball massage? Or give IV verapamil? So you can start voting again. We have very few votes, but still the majority of people suggest either a carotid sinus massage or IV adenosine, right? Nobody says eyeball massage, which is of course very good, because though eyeball massage itself will terminate the tachycardia, it has now been discontinued because of the various dangers probably. So let's see the answers. Yeah. So actually, all three answers are correct, right? But I think in this situation, we are having a young patient who is having a tachycardia but stable. The first thing we would try is some kind of physical maneuver to try and terminate it. And we know that carotid sinus massage is very, very effective in terminating AV nodal reentrant tachycardia, and that's the first thing to be tried. Certainly, nobody will fault you if you say that you want to give some IV adenosine, or in the absence of adenosine, IV verapamil. Now, IV amiodarone is certainly not the first line of treatment as far as we are concerned, because we think that it's easy terminated with other maneuvers and IV adenosine and verapamil. So unfortunately, we know that in this country, IV amiodarone is the first line of treatment for any arrhythmia. So I think we should probably get away from that practice. What do you think, Mehan?
It's right on the money. It's amazing how eyeball massage actually completely disappeared. It only became a historical note nowadays, rightfully so, before people gouged out the eyes. So in clinical practice, I would say carotid massage probably works about 30% of the time, and it may not work consistently every single time. You could probably use cold water splashes, or those type of things could also work. Sometimes bearing down would work equally.
Okay.
The way I come from, most of the months of the year there is no shortage of cold weather, so the cold water is in ample supply, and I have patients who immerse their face in cold water. I have a patient whose husband used to throw a bucket of cold water on the back of the patient, and that breaks the tachycardia. I have another husband who used to lift up a heavy woman and shakes a couple of times, and that breaks the tachycardia. I mean, I'm not joking, but I think when you do that, if you really want to shake your wife up and down like that, probably she will bear down by itself. So that may be how the tachycardia is terminated, and that's basically it's indirect valve style.
I'm sure you will be accused of the shaken wife syndrome there.
In fact, there was a case where recently a baby had been immersed in iced water and immediately went into cardiac arrest and had to be resuscitated. And so immersing in iced water, well, putting ice pack on the face may be a good idea, but probably immersing in iced water may not be a great idea, actually. Okay, so basically, carotid sinus massage, adenosine, and these are things that we want to do.
This is a different patient who is a 64-year-old male, presented with sweating, with discomfort, slightly lowering blood pressure, and ECG was done, and it shows this. So I'll give you a couple of minutes to reflect on this, and as you reflect, you can start voting, and then we'll give you the last 10 seconds as we go along. Okay, now that you've seen the ECG, how would you manage this patient? The options are there, and once you read it, you can start voting.
So what was the blood pressure number there, Asunga?
90/50.
90 or 50. Patient is short of breath and he's sweating.
Okay, let's go to the last 10 seconds. Make up your minds now. Okay, so let's see the responses. Majority have selected the synchronized DC shock, which is good. I think we have done our job educating the physicians if majority goes for this. The hallmark of management here is if any tachycardia which causes hemodynamic instability, the first line treatment is DC cardioversion. So that's the choice here. If you are confused with if you the term electrical defibrillation is generally for ventricular fibrillation. Like all other regular arrhythmias, we would call it a synchronized DC shock. What is also, you may be thinking of amiodarone bolus and infusion, doesn't really apply here because amiodarone takes some time to work, and also there is a medical emergency, the collapsing patient, and also if you give an infusion of amiodarone, the blood pressure will further drop, enhancing the emergency. Carotid sinus massage, harmless, you may try it. And IV metoprolol is not the best choice here. Nobody has gone for that anyway. Right. So if you want to go back on this, it's an extremely wide complex tachycardia. When you see a tachycardia which is really wide, you should be thinking of only two things. One is whether it's a SCAR VT or whether it's a WPW conducting antigradely. Those are the two things that one would think of. Now, if it is so you basically need to decide between the two. We'll go along now. Post-cardioversion, the same patient. Okay, so the answer is clear. In this instance, it's a WPW with antigrade AVRT. It's not atrial fibrillation, but it's antigrade AVRT. So what we did was correct, and then the underlying diagnosis was revealed post-cardioversion. I would invite comments from. Should be yes. Okay, should we go back? If you go back on the tachycardia, extremely wide. If you want to differentiate between the two, you need to look for a delta and probably a P wave. You might not see it in all the leads, but here in the V5 lead, you can see a P wave as well as a delta, right? And in the other leads, you might not see that. AVR, yes, you might be able to see that.
When this is this wide, more than an 64-year-old male, I would statistically, I would have called it the ventricular tachycardia, not knowing. But again, the initial treatment is right. You shock the patient out to stabilize. But not knowing that, if I was just given the tracing, the reason is that this is what I call a wide complex, but it has a right bundle branch block morphology. Lead V1 has a tall R wave, and also the duration of the QRS complex is greater than 140 milliseconds. So when you have a right bundle branch block wide complex tachycardia with a QRS duration greater than 140 milliseconds, that favors highly VT. Now also, again I go back to lead AVR, you look at it, the axis in the limb lead is going upwards towards the right shoulder. So that means the cumulative forces of electrical forces is ultimately pointing upwards, and the only way you can have a positive AVR QRS complex is if it's coming from ventricle. So that, because it's going from down up, if it's going from top down, the AVR should be negative. If it's and if it's going from down up, it's a ventricle. So it's coming from the ventricle. Now, if I take you one more step, the problem with the antidromic tachycardia means the patient has an additional pathway in addition to the AV node, which is an accessory pathway. So it goes down the pathway. So what happens when you go down the pathway, you enter the ventricle. So it's as if you are having a ventricular tachycardia from that point. Do you get my point? So it's almost impossible to separate antidromic tachycardia from ventricular tachycardia because it activates from the ventricle up. So the only way to know is obviously you have an ECG afterwards, like in this case. So statistically, almost always this is VT, but as Dr. Dunuwille approved, this is antidromic tachycardia. But only one question, Dr. Lakiredi will allude that there was one question we had, maybe we want to ask that. So you need to compare the wide complex tachycardia with sinus rhythm, both.
Yep. So if we go back to that original EKG, I think points that are made here is, if you look at all the precordial leads, you have positive concordance of all the precordial leads except for V6. I mean, that kind of throws you off a little bit. You would expect, if the antidromic tachycardia is activating the base of the left ventricle, this V6 would have been positive. So that's one thing to catch. Perhaps the lead location is a little bit funny there. And so what this tells you is the LV is being activated at the base because it's all precordially positive. Negative in 2-3 AVA, that means posteriorly. A negative in 1 in AVL, that means laterally. So you have a posterolateral basal activation. And fast forwarding to the sinus rhythm, you would think, you would see evidence of an accessory pathway that is activating the posterolateral aspect of the LV base. So let's look at the delta waves here. There are positive delta waves in V1 all the way through V5, V6, and you have a negative delta wave in 1 and AVL. And you would think that the delta wave should have been negative in 2-3 AVF as well, because your point of activation of the pathway here is the left posterior base, right? But interesting enough, the positive, the lead 2-3 AVF actually have a positive delta wave, which opens up the question, does this patient have an extra pathway in the location? So there could be, when they're in sinus, you're seeing evidence of a anterolateral pathway. When you're doing an orthodromic tachycardia, you have evidence of a posterolateral pathway. So that is something that you've got to be aware of what could be going on.
That's right. Good point. I thought that you might notice that.
One question that was asked by Dr. Ekanaka, why didn't we ask for the diagnosis? First of all, I think that's something that we want to clarify and we want to make very specific, that when you have broad complex tachycardia, the patient is unstable, you don't need a diagnosis. The treatment is a cardioversion. That's the most important thing.
Yeah, and we do the diagnosis in retrospect. The emergency is due to the fact that if you don't do something quickly, it can deteriorate into fast antegrade atrial fibrillation followed by ventricular fibrillation. This is actually a patient. Luckily, this happened in the EP lab, so we basically cardiovert and you go on ablating. Right? So how would you manage the patient? That's our next question. Now we have the emergency, we got the diagnosis. Now what's the next step? So the options given here are on the board, and then you can start voting now. Okay, let's go for the last 10 seconds. Let's see what the responses are like. Okay, 33% said refer to EP and go for ablation. 63 has made choices in both, like EP or amiodarone and beta blockers as long-term management. Well, if you are to select a single answer, we would go for prefer for electrophysiological study and ablation, although 2 and 4 together are not really incorrect depending on where you are based and what facilities are in existence. Want to invite come in?
We being electrophysiologists, we derive pleasure in slicing and dicing the EKG, but I totally take the point of Dr. Gunawardena. I think don't get carried away from some certain comments we make of the complexities of the cases, but the teaching point here is that if you have a patient with wide complex tachycardia, unstable, synchronized cardioversion, that's number one. And number 2 point is, if you have an antidromic pathway, which basically is capable of going down through the pathway, because some pathways are only unidirectional, either go down only or go up. But when it goes down, the problem is this. And you can have a rapid conduction through the pathway, and I mentioned that yesterday in my talk. And with some pathways are what I call wimpy, they don't conduct rapid, then you are safer. But when it goes this rapid, it takes a second only to convert atrial fibrillation to ventricular fibrillation, and you can have any young person with a normal strong heart dying then and there. and that's entirely curable. So there are very few things in life, whether in cardiology or elsewhere, we cure so, thankfully. I think, no question, send the patient to the electrophysiologist. There is no question. Initially you manage acutely, but you don't give beta blockers because you kill the patient. Why? If you give only beta blockers, what do? You block the AV node. What happens if you block the AV node? Now, when you have even the sinus beat would have a pathway preferably to go down because the AV node is blocked. Beta blockers usually don't block the pathway. Pathway is actually a ventricular muscle. It's a muscle, and beta blockers don't act on the muscle. Beta blockers act on the AV node. That's why if you do beta blockers, you need to give amiodarone, which can block the conduction through the pathway. So you have two things. You give beta blockers to block the node, amiodarone to block the pathway. So don't give beta blockers to this patient because you preferentially kill the patient. But ideally send the patient to the electrophysiologist and thereby, saving a life. And that's all. The procedure is done, and usually low risk, and the patient is cured. And then you don't even need to see the patient afterwards. They are very thankful situations.
Okay, so this is an interesting case, and you have seen the ECG already. Just have a look at it and concentrate on the QRS complexes. There's something abnormal happening there. And again, see if you can locate a P wave. This is a young boy who actually presented with episode of syncope. I mentioned that. Okay, so what are the possible etiologies for this type of ECG? We have several choices: hyperkalemia, digoxin toxicity, hypokalemia, CPVT, which is actually catecholaminergic polymorphic ventricular tachycardia, or there should be hyponatremia, not hyponatremia, but hyponatremia. Right? So if you can't kind of come to a diagnosis, at least make a guess, and we'll see what happens. I can't go back, unfortunately, until we. Okay, so last 10 seconds. All right, so we have votes there. Well, yes, most of you have voted CPVT, and I can understand why, because that is probably the kind of, if you look at the question answer, that's mostly the most likely diagnosis, that's the most unusual one there. Yes, right, okay.
But well spotted, we had to say.
Yeah, well spotted, yes, that's true. Yes. And of course, that is the answer. Now, CPVT is an uncommon, one of the uncommon arrhythmias, which is again a kind of channelopathies, and we see very, very rarely, but we have a family that we are following up, right? And the problem with these patients are that they present with either sudden cardiac death or syncope as their first presentation, right? The ECGs during other times is perfectly normal, and therefore the index case or the first case that you see, you'll never be able to kind of detect them initially. So therefore there's no way of kind of screening for this particular condition. The only thing you can do is that once you have a patient who has either come with a syncope and has not actually died, or unfortunately there's a death in the family and you have a situation like this, is to do exercise ECG in the siblings, but that will bring about a VT. Right. In this particular patient, I think we have two of the siblings out of 3 had the same condition. Right. So basically what the ECG shows is it shows a bidirectional VT, right? And we go back to the ECG now. Right. So you can see that the QRS complex changes as you go on, and particularly if you look at the rhythm strip at the bottom, you can see that there is changing axis of the QRS complex, and that is rare. I mean, it's a very rare situation and seen only in few conditions, and things that we thought were digoxin toxicity is one of the other things that we can see it in. What about any comments on this, Dr.?
The fact that it's a 10-year-old boy, it's a giveaway.
Yeah.
And there was really no reason for. There are only 2 things that should come to our mind when we're looking at this bidirectionally oriented ventricular tachycardia or a wide complex rhythm. One is dig toxicity, the other is CPVT, and I think it's pretty evident. Right,
okay, so basically, so it's caused by the ryanodine receptor in cardiac muscle, and can be diagnosed by exercise ECG, as I said, right? Initially, some time ago, people thought that all patients, or index, at least if they had a survived episode of arrhythmia, should be offered ICD, but they believe that beta blockers should be offered first of all, because there is a good evidence that beta blockers are very useful in this situation. Okay.
And so have a look at the ECG of a 36-year-old female who presented with presyncope. So we'll move on to the question slide. What's the diagnosis? Complete heart block, idioventricular rhythm, severe sick sinus syndrome. You can start voting now. Okay, the last 10 seconds. Let's see what the answers are. The majority have voted correctly. It's severe sick sinus syndrome. Some people have said complete heart block, and a minority have said idioventricular rhythm. Let's go back and have a quick look. What you see here is very slow heart rate. It's patient is extremely bradycardic. Heart rate is about, I think, around 35. And if you are thinking of if you can't see the, you can see the QRS complexes, and you can also see a inverted P wave slightly before the QRS, right? And so that is a retrogradely conducted P wave, and it can happen in very slow junctional escapes, where the retrograde conduction to the atrium is faster than the antegrade conduction from the junction to the ventricle. So inverted P wave very close to QRS, or little far away in this instance, let's say that it's a junctional rhythm. And so since there are more QRS waves than P waves, standard P waves, it goes along with the sick sinus syndrome. It's not idioventricular rhythm. Idioventricular rhythm is a ventricular tachycardia, which is less than 100 beats a minute. I think Evan highlighted that fact during his talk. So idioventricular rhythm doesn't apply here. Okay, so as a management point of view, this low heart rate patient is pre-syncopal, so also the syncope, the patient is symptomatic, so we go for permanent pacing here.
Asunga, did she have any kind of underlying infiltrative heart disease of some sorts? Because it's rather unusual for a 36-year-old to have such severe sinus node dysfunction.
If I see this, I'm sort of wondering too, what caused this on a 36-year-old woman, because I expect this on a 70-year-old person, which is taken up as a degenerative conduction system disease. Now, after listening to Dr. Brugada, could this be this, channelopathy, sodium channel, whatever, the Lennox disease, Leves disease manifesting early? I mean, those things come to mind, because other more commonly, like things like amyloid, which is unusual in this case, sarcoid, which is unusual, I believe. It comes to mind, and sometimes we look into, which is not heard in Sri Lanka, but things like Lyme disease, but Lyme disease doesn't cause sinus node dysfunction primarily. It's more AV nodal. And thyroid problems, I don't know how many of you have seen hypothyroidism presenting as sinus arrest, which is extremely rare, although we always check TSH in these patients. We never find it. But I think it's sometimes worthwhile looking into, and I'm sure with echocardiogram at least, to see whether there is a structural heart disease or any cardiomyopathy or anything.
So there is some evolving data coming from India actually. Cardiac sarcoid is grossly underdiagnosed in the South Asian population than we think it is. So that's something I think should be increasingly looked for. One of the things that may come to the forefront in the next few years.
Interestingly, some of these patients, young patients who we have situation like where just complete atrial standstill, at least sinus standstill. When we go to pace the atria, we find that we just can't get good positions in the atria. So it's a very fibrous atria they have. So maybe there is something like that going on. It's quite possible. Yeah. This might have to be the last case, because unfortunately they were on the hall and we have been kind of going on and on. But anyway, just look at this ECG. Right. So the questions are, again, not a diagnosis, but what are the possible features for syncope in this patient? Could it be a sinus process or slowing? Could it be ventricular tachycardia or ventricular fibrillation? could be a complete heart block, could be 1 and 2 or 1 and 3. Please answer. You need to aim your devices at the computer, really, not there. So just okay. 10 seconds more. Right. Well, we have a kind of, people are divided about what it should be. But a majority think is 1 and 3, which is sinus pauses or complete heart block. And we have some people actually, the risk divider saying either sinus pauses, complete heart block, or sinus pauses and VT/VF. Well, we can go back to that ECG now. One of these ECGs where inevitably you don't make a diagnosis, but it looks normal. Right? And in normal, if you see a patient who has, if you think the patient has some problems like syncope and comes a normal ECG, the most important thing, of course, is always to look at the QT interval. And if you look at the QT interval here, you see that there is a long QT interval and the corrected QT is abnormal. Right? So this long QT syndrome, a ECG diagnosis which is very, very easily missed, and not only just by ordinary physicians, by cardiologists and even electrophysiologists. Right? So that's, I think, a very important thing to kind of think about. Right? Now, yeah. So I think we'll have to stop there because unfortunately, oh, okay, one more case. What kind of do that case?
Interesting ECG. We are back with tachycardia, and this is a 50-year-old male who presented with palpitations. And I'll give you a minute to reflect on this. What's the diagnosis? Whether is it atrial tachycardia, sinus tachycardia, typical AV/NRT, a flutter, or all of above? You can start voting now. Go to the last 10 seconds. Let's see the answers. There's equal split between atrial tachycardia and AV/NRT. Sinus tachycardia has also been voted. People have discounted flutter and the other answer. Let's go back on this. The ECG shows a tachycardia which is narrow complex with a heart rate of approximately about 150, probably slightly below that, and together with inverted P waves. You can see the inverted P waves, and this is what we would call long RP tachycardia. Right? So the long RP tachycardia, the first diagnosis is atrial tachycardia. Of course, there are other things one can consider, and in which case this P is actually belonging to the previous R wave, not to the subsequent one. Right? And then if you look at carefully with the ECG, you can also see another dented area in the QRS complex, which is quite possible that it's a second P wave. So it's actually atrial tachycardia with 2-to-1 conduction. One P wave is engulfed in the QRS complex. It's a slightly uncommon ECG, but that's the diagnosis.
Right. So that brings us to the end of this session. But please don't go. First of all, let me thank our two resource persons and experts, Dr. Lakreddy and Dr. Mevan, for being here and giving some very interesting comments. Right.